Hey guys, this is me. Today we are having a very concise discussion about ischemic heart diseases. So I want to point out at first that ischemic heart diseases means we have lack of blood supplying the heart muscle or the myocardium due to a blockage or an occlusion in one of the coronary arteries that supply the heart muscle. So this is briefly what does ischemic heart disease means. So let's jump into the next section. We are discussing atheroma. Atheroma, I just want to highlight the atheroma here in the image on the right. This is a cut section of the coronary arteries. So this is atheroma, what I highlighted here. It's composed of three things, and this is very high yield. We have a collagen fibrils right here, and we have a lipid and also necrotic debris and smooth muscles. So it's composed of three things. And the keywords I'm going to discuss on the steps of how atheroma is formed is very important. You need to know this. First of all, we have endothelial dysfunction right here. This endothelial dysfunction can be caused by a lot of things like hypertension or hyperglycemia. All of this can lead to a crack right here in the endothelium. So then through this crack, there's a passage between the lumen of the artery. This is a lumen and to the intima. So a lot of molecules leak inside the intima, like LDL and cholesterol. These LDL molecules, when they get inside the intima, they undergo oxidizations. So we have oxidized LDL right here. And they are not supposed to be in the intima, so this induces an inflammation. A sequence of inflammation that lead finally to have macrophages inside the intima. So these macrophages get in here by the monocyte immigration from the lumen through the pores between the endothelium, like this pores, like this pores. So we have a macrophages like that walk around like a bodyguard inside the intima, look for any strange or suspicious thing, and they found the oxidized LDL. So they engulf it or phagocytose this lipid molecules. So we have a foam cells, which is a macrophages with a huge nucleus and have a lot of empty vacuoles inside it. So this is foam cells. And we have an event that is very, very important. This is platelet activations. Platelet activation is caused by the endothelial dysfunction itself. So we have this platelet activation that leads finally to release of a lot of growth factor like platelet-derived growth factor and fibroblast growth factor. These growth factor leads to two things that is very high yield. So we have a smooth muscle migration, and also we have a collagen synthesis. So these two events is occurred by these growth factors that is released from the platelets right here. So the smooth muscle migrate from the intima or from the media that cover the upper layer of the atheroma right here. So this atheroma is embedded inside the artery or inside the wall of the artery. So, and this smooth muscle cover the atheroma from the upper layer. So this is briefly what is atheroma. And it's also composed of collagen molecules. So this atheroma is developed over time, getting bigger and bigger, and finally to an occlusion on one of the coronary arteries. So let's briefly or fast review the steps right here. We have an endothelial damage and also inflammation right here. We have an LDL that slips into the intima. We have LDL that gets oxidized and inside the macrophages. And this fat streaks is formed. Fat streaks is like the atheroma. We can consider them both of things. And we have a growth factor that is activated from the platelets, and we have a smooth muscle migration, which contain collagen and necrotic tissue by growth factors. There is just a couple of notes that I want to point out at last. We have matrix metalloproteinases that alter the atheroma stability. The atheroma stability is only defined by the collagen and the smooth muscle. So this matrix metalloproteinase, this enzyme right here, this matrix metalloproteinase, this is an enzyme that dissolves or cause a destruction in the proteins. So they cause damage to this smooth muscle and also the collagen molecules. And this atheroma is lapide or very prone to rupture. So this is very dangerous, and this is high yield. So we can say also a calcification in this atheroma. Atheroma, if this get developed over time, we can see a calcification. So this can be caused by chronic atheroma or with an advanced age. So now moving on to the next section, we'll be discussing angina. Angina is the first type of the ischemic heart diseases. There's a classic presentation for angina. It will present to you as an old guy in his 50s or 60s with a prominent risk factor like hyperlipidemia or smoking or hypertension, anything that can cause atherosclerosis. So this guy has a pain in the chest. This pain increases with exertion or walking or any kind of activity that require increase in myocardial demand. And the key difference here between the other type of ischemic heart disease is that this pain of angina is relieved with rest. So this guy sit down, took his breath, so this pain gets relieved, and also by nitrate. Nitrate, for the record, is a potent vasodilator that dilate the coronary arteries and relieve this pain of ischemia. So angina is divided into three things, into three types. We have the stable angina. I know the numbers here might be silly, but it's very important. You are going to face this in your NBME questions. So in a stable angina, we only have 70% occlusion in the coronary artery. So there's an atherosclerosis that leads to an occlusion of 70% or more. So if below 70%, there is no significance of this occlusion. So it will be definitely a wrong answer in the question. And there is a second type, which is unstable angina. And unstable angina, there is unstable, so there is a rupture in the atheroma. So there is a thrombosis that will be formed above this rupture of atheroma and will lead to a 90% occlusion of the coronary artery. So there's a 10% only left in the coronary. So, and this unstable angina is more prone to progress to myocardial infarction. So this is very dangerous. And the third type, and this is irrelevant here, this is vasospastic angina. It would present to you classically as a younger guy in his 40s or 30s with no significant risk factor, no smoking, no hypertension, no hyperlipidemia. But he was in a party last night and he consumed cocaine or alcohol, and these are potent vasoconstrictors. So they constrict the coronary arteries, they cause spasm in the coronary arteries, and this leads to ischemia. And people with low nitric oxide in their endothelium are very prone to this. So now moving on to the next type of ischemic heart diseases, which is myocardial infarction. So there's a classic presentation for the pain of myocardial infarction, which is acute persistent stabbing pain in the chest. But this pain is not relieved with rest or not relieved with nitrate. So this is how you're going to differentiate between the pain of angina and the pain of myocardial infarction. So you also need to know that there is an elevation of the cardiac enzymes like cardiac troponins, and this represents an irreversible injury of the cardiac myocytes, and this is very high yield. So we can divide the myocardial infarction into two types. There is STEMI, which is ST segment elevation myocardial infarction. As the name implies, there is an elevation in the ST segment on the ECG. So there's a classic presentation for STEMI in the questions. It will present you as an old guy in his 60s or 50s with a prominent risk factor like smoking or hypertension or atherosclerosis. So this patient will present to you in the emergency room with a diaphoresis, accelerated heart rate, and low blood pressure like 90/60. This patient have persistent stabbing pain in the chest that is not relieved with pain or that not relieved with rest or with nitrate. This is a persistent pain. And he has an ST segment elevation in a bunch of the cardiac leads like 2, 3, and AVF cardiac lead, which represent an inferior myocardial infarction. So this is classically how it's going to show up in the question. So regarding the pathogenesis of STEMI, so we have this unstabilized atheroma. When this atheroma rupture, there's a thrombosis that is formed above this atheroma and lead to 100% occlusion of the coronary artery. And this is very high yield. You need to know this. There's 100% occlusion of the coronary artery. And since there is a severe occlusion in the coronary artery, we know that the whole thickness or the whole myocardium is involved. So not just the subendocardial layer or one layer of the myocardium. I'm going to explain it further in the next slide. So you need to know that the whole thickness of the myocardium or transmural, there's a transmural infarction or transmural involvement of the myocardium. So there is a necrosis and a tremendous damage. And some of the NBME questions will present to you as a gross picture of the heart with the white plaques on the gross picture of the heart. So, and they are gonna ask you why this white plaques is formed. And this represents a previous myocardial infarction that has a necrotic tissue, and this necrotic tissue undergo replacement by a fibrous tissue or a granulation tissue later on. So the other type is NSTEMI or non-elevation ST segment in the ECG. So this involves only the partial thickness or the subendocardial layer of the myocardium, but it will present with the same presentation as the STEMI. So we have also this unstabilized atheroma that undergo rupture, but the thrombosis that is formed above the atheroma right here is only lead to a partial occluded thrombus. So there is only a partial occlusion. So in this slide, I'm going to tell you how to differentiate between the different types of ischemic heart diseases and how to approach this kind of question. First of all, you need to read the complaint of the patient very well. If this patient presents to you as acute persistent stabbing pain in the chest, and this pain is not relieved with rest or with nitrate, so you need to know that we are dealing here with a myocardial infarction. So whether it's a STEMI or NSTEMI, both of them has an elevation in the cardiac enzyme like cardiac troponins, but how to differentiate between both of them by ECG. In STEMI, there is an ST segment elevation, while anything else can be NSTEMI. This is how to differentiate between the two types of myocardial infarction. On the other hand, If this patient presents to you as a temporary pain, this pain is only elicited when there's an increase in the myocardial activity or exertion or with walking, and this pain is relieved with rest and nitrate. So you need to know that we are talking about angina right here. So how to differentiate between two types of angina? Unstable angina, you need to know that we have a normal ECG, but in unstable angina, ECG as well can be normal, but most of the time there is an ST depression. So this is very important.